We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. Basically, endocrinology is all about investigations, and we want to do tests in the right way, the right time, interpret it correctly. Because if our interpretation of the testing is wrong, then there'll be no point doing everything, and we'll be doing a mismanagement in that perspective. So this is going to be a dialogue. The next 3 sessions are going like that. So we'll have a dialogue. So we have Alapan here, then we will have Dhwani, and Vibha will talk about the unique thing subsequently. So this is like a dialogue as to what case scenarios we see and how those case scenarios can help us learn about pediatric endocrinology. So hormone assays, as I said, are vital in pediatric endocrinology. They are often a game changer, but they are often complicated. There are so many things happening in terms of how to send the sample, when to send the sample, which sample to choose, which technique to choose, and how to interpret, which causes so much confusion. So we need to be very clear about assays which should be precise, accurate, and interpret it very well. Now, endocrinology is a challenging condition because we're dealing with large molecules. We are dealing with a wide range. Now, if you look at sodium, you're talking about a range of around 130 to 150. For TSH, you're talking about a range of minimum of 0.4 to 5. So it's like 1000% changes in terms of the interval. So this is something which is very important. Things are changing during puberty. Levels will go up and down. There will be a lot of other diurnal variations as well. So this needs a lot of understanding, and I think this talk is important. So why do we do an endocrine test? One is just to do screening, like we want to rule a particular condition out. There you want to have a test which has got a higher sensitivity. Then to establish a diagnosis, you want a test which has got a higher specificity. Then to monitor, of course, we talked about 17-OHP, androstenedione, things like that. But the key message is do a test only if it changes your decision. Do not do the test unnecessarily. Only if you have a high pre-test probability. I'll talk a bit about that. And if it changes your treatment effect. So we'll have the first case coming on to Dr. Alapan.
Good afternoon, everyone. So we have this 10-year-old boy presented with growth failure. The height was short, 127 centimeter with standard deviation score of -2.4. Weight was 14 kg, which was a bit less, -4.8 standard deviation score. The screening normal workup was normal initially, and someone did a IGF-1 level and it seems to be low. So Dr. Anurag sir, I would like to know whether this test is necessary at this particular point of time, and what is the importance of IGF-1 in this setting?
So what we're seeing clearly, this child is short. So definitely in short stature, we talk about screening for various causes. But the first thing is a clinical assessment. So what you can see clearly here, what is more affected? It is height or weight?
This is the weight more affected.
So this is more likely to be a nutritional cause. So this low IGF-1, I would say, first of all, it should not have been done. IGF-1 is not a good test in a malnourished individual. And this basically will give you a false diagnosis. And that's why the growth hormone stimulation test was normal. So when you are doing endocrine assessment, there are a lot of errors which can happen from when you're prescribing a test and when you're interpreting a test. You can have issues in terms of the test, the timing, as I said, the sample, how you processed, which technique, and all these errors can be there. So errors can be pre-analytical, in which before you're writing, analytical, or post-analytical. So what do you think is the most common form of errors in endocrinology? Is it pre-analytical or post-analytical?
It's a pre-analytical.
So it's actually more than 50% errors are happening at our level. So it's first of all we to blame before we start blaming, and 50% there and 20% in terms of post-analytical. So 70% errors are at the level of the treating physician and 30% may be at the lab level. So you need to be very cautious in that regards. So the type of test you have sent, sample, labeling, processing, then 30% errors may happen, which we'll talk about, whether there's the issue of precision in terms of quality, interference, and other things. And then very important, if you're not interpreting the levels properly, the range is given wrongly, the reporting is wrong in that regards. So if I go back to this case, as I said, this is a wrong test. It should not have been done in a malnourished child. So malnourished and a liver disease, why do IGF-1? This is not really required. So generally, we tend to do a direct hormone assay for large hormones which are stable, like FT4, cortisol, and testosterone, which are not changing a lot. We tend to look at co-secretors. So where do you do co-secretors, Alapan?
Like in case of C-peptide level.
So when your primary molecule has a
less stability in terms of
short half-life. So classical example is insulin and C-peptide and copeptin and the AVP. So other thing you do is, of course, to look at the effect of the particular hormone, and the classical example is ketone. So the most sensitive marker of hyperinsulinism is hypoketotic hypoglycemia. So look at the effect. If your phosphorus is low, your PTH should be high. If your phosphorus is high, your PTH effect is not there. So always look at those parameters first before you go ahead otherwise. And of course, you can look at metabolites like cortisol in that regards.
So this second case, a 15-year-old boy presented with obesity. He has all the features of Cushing syndrome like hypertension, striae, blood pressure was elevated. But the overnight dexamethasone suppression test was suppressed. It's 40 nanomole per liter. Sir, in spite of having all the syndromes of Cushing syndrome, do you think this test is reliable on this regard?
So I think a lot of things have to be looked at. Most important thing would be what sort of sample you're using. So we know that we have the whole blood. The whole blood has got a lot of enzymes. So whole blood is only good for point of care tests, like doing ketones, like if you want to do blood sugar. So only labile rapid changes you can do. Then if you remove blood cells on, then you get the plasma, which again has got multiple factors. So plasma again is not something which is very, very good test. It's a labile one, they're dynamic changes. So it's good for things like ACTH. There you want to do plasma. For all other scenarios, you use serum, which is much more stable, where you have removed the clotting protein, and the serum would be quite good and stable for peptides and other steroids. So whether you're using the whole blood, plasma, or serum will make a difference, because matrix does have an impact in terms of hormonal assessment. You can sometimes use urinary, as we were discussing, for especially for steroids, and we talked about salivary, Dr. Sugandha talked about, in terms of cortisol or 17-OHP also. You can do that for these small molecules. So now in this case, the ACTH level, which was done on serum, was found to be elevated, but MRI was normal. So serum ACTH is not good. We should have gone with
plasma ACTH.
We should have gone with plasma. So selecting the type of sample you are sending also is very, very important in that regards.
So in the next case, 11-year-old boy presented with growth failure. He had a significant growth failure of height standard deviation score less than -5.4, has an immature facies, and all the screening investigation, initial investigations were normal. So someone did a basal growth hormone level and it came to be low, and he was diagnosed as growth hormone deficiency. But sir, I would like to know whether this basal growth hormone level is any role in this child.
So compared to the previous case, the pre-test probability of growth hormone deficiency is much more higher in this case. This is very short and has immature phases. But basal growth hormone, as we know, growth hormone has a pulsatile secretion. So this basal growth hormone is of limited role at all. So if you have a pulsatile secretion like growth hormone, cortisol, prolactin, and testosterone, you have to be very, very careful in that scenario. You can also have diurnal variation. The classic example is that of cortisol, which is highest in the day, lowest at the night. So you have to choose when do you want to that particular sample. If you're looking for excess, you will do in the
night time.
In the night time. If you want to do for deficiency, you will do in the morning. So that becomes important. Then there are some hormones, particularly the reproductive hormones, the LH, FSH, progesterone, 17-OHP, which we discussed, testosterone, who have a marked menstrual variation. So there you have to decide what day of period, proliferative or secretory, where you want to do it in that regards. And then you have seasonal variation in thyroid, in the setting of vitamin D, in the setting of estradiol. So here, of course, you have a problem of pulsatility. So what you could have done is you can do a pooled sample like LHFSH. So how do you pool the sample? You take 3 samples, do the value and average it. So you take sample 3 times 0, 15, 30 and take all the values and average it. So you mix all the 3 samples and then do the single value. There's no need to doing three values there. Then timing, cortisol, as I said, morning for deficiency, night time for excess. Co-secretion like C-peptide may be a good idea, and you can do a growth hormone dynamic. So coming back to this case, what do you think would have been the best strategy?
Best would be, we would rather want to go for the growth hormone stimulation test in this child, because we are not suspecting any growth hormone insensitivity in this case. So
GHST will be important. So only indication Alapan has said is if you have a very strong possibility of growth hormone insensitivity, cost is an issue, get a basal growth hormone. If it's more than 5 in a short child, that could be growth hormone insensitivity.
Now the 13-year-old boy presented with weakness and pigmentation. Sodium level is normal, potassium is 4.6. Cortisol done was in the lower range.
So pigmentation is a common finding. We can see pigmentation in various conditions, B12 deficiencies, some infections, some other conditions. So it does not mean alone that if you have pigmentation, you will have cortisol deficiency. So the key question here is this cortisol significant or not? So isolated cortisol deficiency, even if it at 8 a.m., I would not consider it significant unless there is hyponatremia, unless there is hypoglycemia, unless there is stress, or if you have a ACTH, which is more than 3 times the upper limit. But what is the time of this cortisol, Alapan?
It was done in the evening. So probably
So this cortisol, again, we remember that there is a distinct peak, which is happening in the morning, and the levels are low at evening. So if you do the cortisol at evening, your levels will be low. So clearly the error here, once we did on 8 a.m. was corrected. So what is your key message here?
we should see the diurnal patterns, which hormone we are doing,
Yeah.
and we have to go according to the.
So only do the sample when is the right time in that regards. So this was a wrong timing which is there.
Okay. Now the next case with a 15-year-old girl with hirsutism, menstrual irregularities were there. Hirsutism was in a moderate level with FGS score of 12, and someone did LH and FSH level. LH was raised, also the FSH one.
So what does a high LH mean? Let's forget about this sample. What does high LH mean? Is it diagnostic of PCOS?
No, sir. It could be a variation of normal variation also. We have to see when the LH has been done and also the FSH has been done.
And the other thing is that LH is not driving your PCOS. This high LH may actually be the effect of PCOS rather than the cause of PCOS. So don't give too much importance to these LH, FSH values. What's more important is your Ferriman-Galway score. What's more important is your testosterone level. So that becomes critical from that perspective. Now, my question is, what was the time of this LH? Because we know that you can have severe peak of LHs, which is happening in between. And if you do at this time, your entire value will be compromised. So this was done at a intermediate time of period.
Yes.
So day 2 period, now the levels are normal. So what does it mean?
That means this is just because due to the ovulation and this level was high, but we've done the day 2 level, it was normal in this child.
So it was a wrong timing.
So now the 6-month-old girl presented with seizure. Calcium level was low, with phosphorus level was also low. PTA is done, was on the lower side. Also the vitamin D level was on the lower side.
So now your question is it PTH deficiency or vitamin D deficiency? So as I said, one marker is the effect of the hormone. What is the effect of PTH deficiency?
The phosphorus should be in the
high. And what about vitamin D deficiency? It should be low. So if you go just by your biochemical parameters, this picture is fitting into a vitamin D deficiency rather than a PTH deficiency. So before doing anything, I'll say this PTH I am very, very doubtful of. So that becomes important as how have you transported. Now, many of these peptides like ACTH, PTH, insulin, they would be very sensitive to temperature changes. So you can't just say, okay, go to the collection center, give your sample, and by the time it goes, it's already destroyed. You also have to think of other samples where you don't freeze like ADH or IGF-1, or those who are not affected by temperature. You can put it there, growth hormone, cortisol, TSH. But remember these 4, they are of absolute importance in which you want to avoid that. So now what has happened then?
Then again, the PTH is done in repeatedly, and this time the sample was sent in on the eyes and immediately after collection. So the repeat PTH is shown a high level 250.
So very important is just to ensure that your sample is taken properly.
Now this 7-year-old girl presented with early puberty, breast age of 3 and pubic hair of 2. Bone age is 10 years, a bit progressed. LH FSH is raised in consideration of a 7-year-old girl, but estradiol level is less than 5. So
what do you think? This is a progressive puberty or this is a slowly progressive puberty?
I think this is a considering the bone age and the breast stage in this child at this 7 years of age. I think this is a progressive.
So there is a non-estrogen cause of early puberty and a non-estrogen cause of advanced bone age, do you think?
No, I think the estradiol values has been done in another methods like.
So this is a very, very common report we see. We see LH is high, FSH is high, estradiol is 0. And then the patient will tell you how is estrogen 0 and you still have a precocious puberty. So till now, I all talked about pre-analytical issue. So this is again an analytical issue, but you can say also you could have said that don't do with this technique, do via different techniques. So techniques are very, very important. We know that there are 2 types of techniques, the immunoassay, which is most commonly used by most counters and rapidly done techniques. They are good for large molecule, large volume peptides, but they are not very good for steroids, particularly for estrogen, testosterone, and for rarer situations, cortisol in the newborn, immunoassays are not very good. There you will like to go ahead with something like mass spectroscopy, which separates the various hormones based upon their mass and charge ratio. And that's how you distinguish between the 2. They're good for smaller molecules. You need only small volume. So if you're looking at estrogen in males, testosterone in females, estrogen in prepubertal girls, if you're looking at cortisol in infants, think of a possibility of mass spectroscopy. That will be a better way to go forward in terms of that technique. So this is the wrong technique which was used.
Now this next case, 12-year-old boy with 21 hydroxylase deficiency, hydrocortisone, he was on hydrocortisone 15 milligram per meter square per day. Now the 17 OHP level is 4 nanogram per ml. As you all know that we have always in a target cutoff of 3, the 17 OHP level was a bit raised from that. Again, the next value, it was done from the another lab that was showing that it was 2.4. Sir, why this discrepancy is there?
I think already very nicely Dr. Sugandha has mentioned that we should not target at the lower limit. We want to keep it at a 3 times the upper limit. That is also because of the sensitivity issues. So when we talk about the comparison of a particular assay, we compare this to a gold standard. And we also talk about precision and accuracy. So what is the difference between precision and accuracy?
Accurate means how many times the level is giving the right diagnosis, and the precision is how many times the report is giving the similar kind of values.
Yeah, so if you repeat the same sample multiple times, your value is going up and down, or is it going on one particular side? So if you can see, you have this form of this thing which is accurate and precise, while here you have a systematic error and you can go up and down. That will be a random error. So every test will have variability, and this variability would be very significant. At least 20% variability is allowed. So when you talk about the variation, 20% coefficient of variation is allowed. So this 2.4 and 4 to me is the same. It doesn't make any difference because it's 20% up and 20% down. So don't worry about these minor changes in these scenarios.
Okay, the next case, 10-year-old girl with hypothyroidism on thyroxine supplementation of 100 microgram. Her TSH was 54. Asking about the compliance, it was a good compliance, and the child is euthyroid. So we repeated the sample and TSH was 2.5.
So again, good that you repeat the TSH. So if you have a clinical biochemical discordance, then you should do a resample. Now, why this TSH is high there can be many explanations, but one of the most logical explanation often happens is what is known as a carryover effect. So maybe you had a patient whose TSH was more than 1000. It was there, and some amount of that sample, if the washing was not good enough, remained in that container, and the next sample, the level goes up. So the lab should have a mechanism by which they should really look at that if there is a possibility of carryover, they should repeat it. So again, saying if you have one erroneous report which is not fitting into the clinical picture, don't. So you are the final judge, not the report. So this is something which is important.
Now this next case, 16-year-old girl presented with galactorrhea, the high possibility of hyperprolactinemia. Now his prolactin level came low, 16 picogram per ml, but she has headache, vomiting, and a MRI showing a large adenoma. So in spite of having all the symptoms and galactorrhea, why sir, this prolactin level is not high?
So generally speaking, if you have galactorrhea, your prolactin should be more than 100. Now, theoretically, you can have a non-functional adenoma in which prolactin may not be very high in this scenario, but because of galactorrhea, I would be thinking this is a functional adenoma. So there is an analytical issue which is coming, and the most common analytical issue for hormones who go many times their basal level is what is known as a hook effect. So if you look at scenarios like HCG, prolactin, TSH or calcitonin, these are pretty much like tumor markers. Their numbers can go 100 times, 1000 times. Normal prolactin is 40, but you can have prolactin up to 4000, 8000. So in this scenario, after a level, you have a falsely low level, and this is what is known as a hook effect. So how do you correct for hook effect?
So as we know that hook effect is due to the excess of antibodies in the serum, so we can dilute the serum so that antibody concentration will be a bit less.
Not the antibody, the ligand. The ligand is too high. So if you dilute the ligand, you will get that. So you should do it with a diluted sample. You will get the better result in that regards.
So now the next case, a 17-year-old girl presented with follow-up of a papillary carcinoma of thyroid. She has undergone the surgery and radioiodine ablation. Now the thyroglobulin level was undetectable for follow-up, but the radioactive iodine scan is showing a lesion present in the neck. Sir, do you think that this radioactive lesion is already present, but why this thyroglobulin is undetectable?
Yes, so thyroglobulin is supposed to be a very sensitive marker of any thyroid tissue. Now your radioactive iodine shows that there is a thyroid tissue, but you have no biochemical marker. So it doesn't mean that you don't have any thyroid tissue. So what I would like to go ahead is to look at some other possible causes. And one very important thing is antibody. See, ultimately, when you're doing an immunoassay, you need an antigen to bind to the antibody, and then you have the second antibody. But suppose there is already an antibody to thyroglobulin, it will take off this antigen. And that's why you will have a falsely negative test as far as this is concerned. And this is particularly common for thyroglobulin. And this is very, very important. You will have a falsely low. You should then go ahead with a non-competitive assay like GCMS, which will give you a correct diagnosis. Or if you measure anti-thyroglobulin antibody, that will be a good thing. So a big message is that if you are really thinking of a follow-up of thyroid carcinoma, always do a thyroglobulin antibody as well, because that may be positive in that regards.
Okay. Now this 11-year-old boy presented with lethargy. T4 level was low with a TSH 3.4 in the normal range. There was no goiter. TPO was negative, and test of total T4 and T3 level was normal.
So again, this is a scenario which could be a central hypothyroidism. So do you think this could be central hypothyroidism?
Before labeling something as central hypothyroidism, I would like to consider a repeat test in this.
So what is important to understand that if you have a low T3 or T4, TSH should be sky high. If the TSH is below 20, you should think of central hypothyroidism. But yes, before you label that, because then you will have to do an MRI, you have to do a cortisol, you have to do a prolactin, so many things, you better do something else. So what could be going wrong is heterophile antibody. So what is a heterophile antibody?
Heterophile antibodies are the antibodies that is present in human beings, but that is actually against the some animal species, cross species.
And so there is a cross reactivity of these antibodies, and we know all these assays are essentially based upon some like horseradish peroxidase. There are other ones which are originating from the animal species. So these antibodies can inhibit the activity of these enzymes, and therefore you may have a falsely low or a falsely high level. So heterophile antibody again can explain you discrepancy which is noted. So do it on a different platform. What do you mean by a different platform in this setting?
That means we can do it from a different lab also.
Not on a different lab. Suppose they have various ways. Some do via the Roche, some do via Alexis, some do using Beckman with Coulter. So if you do only with Roche and the other lab is using the same machine, they will give the same report. But if you do through a different machine, and you ask a lab whether you're doing with a different machine, then you will get the right result. So this is what the platform would be.
You have to ask whether
what is the
serum they are using.
No, which machine they are using, because each machine will use different serum and other parameters. Yeah.
So
yeah,
14-year-old boy presented with gynecomastia. Breast is 2, testicular volume is 12, and pubic hair stage of 3. His LH FSH level was 1.8 and 2.4 respectively, and testosterone level was 120. And prolactin done, it was 120 picogram per ml.
So a lot of people with gynecomastia, they get a prolactin done. But does this hyperprolactinemia cause this gynecomastia? Do you think?
I don't think so, because the prolactin, how it causes gynecomastia is due to the hypogonadism.
So if your prolactin is causing gynecomastia, your testo should have been low. So if you have a normal testo with a high prolactin, I would doubt whether this prolactin is right or not. Now, we talked about hook effect, where you had clinical features, but the levels were low. Here you don't have a clinical features, but the level are high. So this is the opposite of hook effect. And this is what is known as a macroprolactin. So macroprolactin means because of the antibodies, a lot of prolactin molecules which are non-functional fuse with together, and you will get a very, very high level. So this is clearly a case of macroprolactin in this scenario.
So now this 14-year-old boy presented with delayed puberty, testicular volume of 4 ml with pubic hair stage of 1. Testosterone level is undetectable. And the repeat testosterone done was just in the puberty level of 24 nanogram per ml.
So if your final diagnosis depends only on testosterone levels, you will always get confused. You have to look at the clinical picture. What testicular volume is 4 ml. It means what? He has already entered into puberty, or he is just entering into puberty. So in this scenario, I would be more cautious in that regards. Now, when you say undetectable, the lower limit may be 20 for that lab. So anything which is 16 or 17, it will say undetectable. So you need to remember that there is always a coefficient of variation. And if the coefficient of variation becomes more than 20% on both sides, the lab will say, this is my range. I am allowed to report only if the coefficient of variation is less than 20%. And closer you go to the extreme, the more variation will happen. Like in blood glucose, when you use glucometers, they are good for high or they are good for low sugars.
They are good for the high blood glucose.
But their coefficient of variation is more for the low sugars. Similarly, for estrogen, they have been developed for reproductive endocrinology. For females whose estrogen is 100, they are not been developed for estrogen levels of 8 or 10. So same thing is about testosterone. They are for adult males. At lower levels, the coefficient of variation will go very, very high. And that's why you need to be cautious about that. So this you need to do using a different technique. Or I would say forget about it. Just follow up the child. He's already has a testicular volume of 4 ml at 14. He will progress.
So this 8-year-old girl with short stature, height was 128 centimeter, not very short, and having a normal screening test. Growth hormone stimulation test was done, which was showing, according to the guidelines, it was a partial growth hormone deficiency. I would like to know, sir, whether this growth hormone stimulation test is required considering the pretest probability in this child.
I think the most important thing is that the test is only going to change the probability of the diagnosis. If your pretest probability is very, very low, even if the test is positive, your post-test probability is not going to be very, very high. That becomes very, very important. I'll give you an example. You have got a very good test which has got 90% sensitivity and 90% specificity. The prevalence here is reasonably okay. And here you are finding good positive predictive value because you have got a high prevalence in this regards. Now, in second scenario, if the prevalence is only 10%, now what is happening with the same sensitivity and specificity, your positive predictive value has come down. So if you do not think that this is GHD, please do not do a growth hormone stimulation test. Only do if you have a high index of suspicion, then only these results will make the difference. Remember, none of these tests are perfect. You will have variations and you will unnecessarily label somebody as GHD or you will exclude them as non-GHD in that regard. So as the prevalence increases, the positive predictive value goes up, the negative predictive value goes down. So always look in terms of prevalence. So here you should not have done the test.
Okay, now the next case, 12-year-old boy presented with delayed puberty concern with testicular volume of 2 ml and pubic hair of stage 1. Bone age is around 10 years and the hormonal investigation has been done, which was showing that undetectable LH, FSH and testosterone level. Sir, I would like to know whether this child actually required this kind of investigations considering the
so this child, if you go by biochemical reports, is hypogonadotropic hypogonadism. But every prepubertal child is hypogonadotropic hypogonadism. So why do you need to even do the test? So unless you reach the criteria, which is 14 years and TV less than 4, you should not even do the test. This is so common in girls and boys where we get these tests and it causes more confusion. Nothing to be done. They will say, do a MRI head and then things will go on. Similarly, if you have no breast, they will do an ultrasound which shows no uterus and then MRI, karyotype and everything is going to be done. So in endocrinology, often it is good to not do things rather than overdo. So this is definitely not required. You know that during this phase from around 1 year till around 13-14 years, you will have zero hormones. So everybody from 1 to 14 is the same. Don't do the endocrine test in this regards, and that becomes important from that perspective. You wait for 2 years, what's the harm? This is not the criteria because around 15% boys of his age may still be too. Yeah, so we should have been followed up. Yeah. So we have to counsel them. So it's our task. So because otherwise you will get these sort of reports. So the criteria is 14 years. We should follow this. Yeah, no worries. Yeah.
So the next case, 12-year-old boy presented with lethargy. Free T4 level is low with TSH in the TSH level was 12. Cortisol done was low. The ACT is of 5.6 picogram per ml. And there was undetectable gonadotropins level as well as testosterone.
So I think this is very, very important test. So if you look at FT4, the TSH is 12. Now, do you think this TSH about 10 is primary or central? Forget about FT4.
Above
If
10,
you had not done FT4, TSH was 11, 12, what would you have thought?
we have thought about the primary hypothyroidism.
So very importantly, always do a FT4 when you're doing TSH. Do not just do a TSH, number one. Now, if your FT4 is low, do you think this is still primary?
No, we have to see in the contextual assessment of FT4 and TSH. If FT4 is low, the TSH should be sky high, more
Yes.
than at least 12.
So there is a log linear relationship between FT4 and TSH. If your FT4 is low, your TSH should be very high. If your TSH is detectable with a high FT4, you are basically dealing with thyrotoxicosis or TSH adenoma. While if your TSH is up to 20 and you have a low FT4, this is central hypothyroidism. So again, this contextual assessment is very, very important. And this is relevant for other conditions as well.
So the similar case, a 7-year-old girl with tetany presented with hypocalcemia and hyperphosphatemia. Creatinine level was normal. PTH is in the normal range as reported by the laboratories. So,
so here the PTH is normal. Do you think you'll have to work up for other causes?
Sir, if you consider for the calcium level, in the low setting of the low calcium level, the PTH should be more than at least 70.
So PTH should be sky high. It should be 200, 300, at least more than 70. So this PTH, which is quote unquote normal, is not normal for hypocalcemia. And you already see high phosphorus, which basically means that PTH is not working here clearly. So this is clearly a case of hypoparathyroidism. So the same level of PTH may be low in hypocalcemia, normal in eukαλcemia, and high in hypercalcemia. So if your PTH is 24 with hypocalcemia, that's low. 24 with normal calcium is normal. 24 with high calcium is high. So you have to always see, when you say PTH, I will say what is the calcium. When you say TSH, I'll say what is the FT4. You say what's the ketone, you will say what's the insulin and glucose. That becomes important. So you have to have a systematic association. So this again is inappropriately low level of PTH. This is actually hypoparathyroidism. So to summarize, there is always an overlap of physiology and pathology. It impact of age, puberty, and disease. You have to correlate it clinically, and testing should be done only if it is necessary. So